Ben Higginbotham, great partner over here, Tim Martinez, and we have a labral tear in the shoulder. Our patient is a 35-year-old investment banker from downtown Austin. She was referred to our clinic with a post-operative labral tear repair in her right shoulder. Prior to surgery, our patient complained of shoulder feeling unstable, some clicking, and mostly pain. She tried doing a non-operative approach, but the pain came back and the result was her having to get surgery. She participates in recreational golf on the weekends with her business associates. Her long-term goal is to be able to return to play and have a round of golf pain-free by August 5th of 2018.
Okay, so a little bit about the labral tear. So labral tear is the detachment of the superior labrum from the glenoid fossa, anterior to posterior, and can sometimes involve the long head of the biceps tendon origin. So common causes of injury include repetitive overhead activities, traumatic fall, an outstretched hand or foosh, and a direct blow to the shoulder. It could be accidental or it could be in contact sports. Symptoms include persistent pain, clicking, or instability. Emergency situations would involve the labral tear compromising the axillary nerve or axillary artery. Possible concerns could involve subluxation of the shoulder due to instability, torn ligaments and tendons that attach to the labrum, a Bankart lesion, and rotator cuff tears.
The non-operative treatment of a slap tear include rest from aggravating activities, a corticosteroid injection, physical therapy that focuses on the endurance and strength of the rotator cuff muscles, and scapular stabilizers.
Post-operative rehabilitation is based on the specific surgical procedures in the anatomy that has been affected. So there could be the muscle tendons, ligaments. If the axillary nerve or artery was compromised, you would have to take that into consideration when you are doing the rehab. It will focus on protecting the healing labrum while gradually restoring range of motion, strength, and dynamic stability of the shoulder. For non-operative rehab, it usually calls for a corticosteroid injection as said above. In a study by Shen and others, 12 of 46 subjects that received one corticosteroid injection had to receive a second injection. 5 of the 12 who received a second injection had symptoms relieved, but the remaining 7 had to end up getting arthroscopic slap repair.
For phase 1, post-op, we had 0 to 4 weeks, and our exercises were in the internal, external, isometrics, and neutral against the wall, a scapular retraction, pendulum swings, pliable squeeze and horizontal adduction, supine assisted arm elevation, behind the back internal rotation with a strap, rhythmic stabilization with the clinician, and stress ball squeezes. Exercise for our phase 1, we'll be performing internal external rotation isometrically against the wall, like so. Patient will be pushing against the wall. Other side, patient will still continue to push against the wall.
For the next exercise, we're going to do rhythmic stabilizations of the shoulder. So kind of working on really early proprioception. All right, so you're going to have the patient, you're going to assist them and passively flex their shoulder to wherever there's no pain. And then you're going to tell them to hold that position. And then you're going to apply pressure in different angles while using both hands around, so that if they cannot hold it, then you can stop it and stabilize it. But you just want to apply different directions and tell the patient not to let me move them and just to stabilize their shoulder by themselves. All right, so our phase 2 is 5 to 8 weeks post-op. We would start increasing range of motion, or working on the range of motion, working on the strength of the dynamic stabilizer in the shoulder. So we would do pulley for shoulder abduction, adduction, and flexion and extension. Prone plyo ball, I, Y, and T drill with your thumb up or forearm in neutral. Side lying external rotation with the dumbbell. TheraBand in all planes with your forearm in neutral, so internal, external rotation, abduction, adduction, and then flexion, extension of the shoulder. Prone row with the dumbbell, UBE or upper body ergometer. Joint mobilization, grade 1 and 2 for shoulder flexion extension because you were just focusing on pain at that point. And then plyo ball, push against the wall.
So exercise for our phase 2 to work on some range of motion will be prone, IYT drill with our thumbs in neutral, and allow the patient get down, chest on the ball, and working on scapular retraction. We'll have them perform I, T, and then I, Y, T.
So for our second exercise in phase 2, we're going to perform TheraBands and all shoulder planes. So we are going to use a TheraBand and we put it inside the door, so it makes it actually a great at-home exercise that they can do because you just give them a TheraBand and they can do this anytime. So we're going to start off with internal rotation with the forearm in neutral. So you're going to pull towards your chest, keep your elbow in towards your body. And then for external rotation, it's going to be the opposite. You're going to go away from your body. So then you want to do flexion right here, going up, and then extension, going back and down. And then for adduction, you're going to start away from your body and then go towards it. And then for abduction, you're going to want to lower the TheraBand. And then you are going to go up and away from your body.
For phase 3, that'd be post-op weeks 9 through 12, we'll still be working on strength, range of motion, a little bit of proprioception, and our exercises were standing 90-degree internal external rotation with TheraBands, shoulder shrugs with a dumbbell, Bosu ball in push-up position while stabilizing the medicine ball, seated medicine ball chest passes to the trampoline, a seated row, standing IYT drill with a dumbbell, the STAR test for the upper extremity, D1, D2 flexion extension for the upper extremity. We also have our simulated golf swing with just a towel, not as max effort. So exercise we're going to have for our phase 3, we're going to have the patient with his Bosu ball, and we're going to have him in the push-up position and stabilize the medicine ball as we're moving it around.
Okay, for our second exercise in phase 3, we're going to do simulated golf swings. You can use a bolster or a towel to simulate the actual golf club. And we're going to do it on an TherEx pad to work for our proprioception. So you're going to stand on the TherEx pad, and then you're going to act like you're about to swing, and then you go back into shoulder abduction, and then come into adduction. So, and you don't want to do this in max effort because you are still in phase 3. And so phase 4, which is the last phase of the rehabilitation process, we're going to be focusing more on functional and return to play activities. This is going to be 13 to 16 weeks post-op. So you can do overhead trampoline throws with the medicine ball, internal external rotation throws with the medicine ball with your shoulder at 90 degrees abduction, over the shoulder wall passes with a medicine ball on the TherEx pad, wall push-ups with a release off the wall, alternating forearm to palm planks, single arm adduction and abduction with a sliding board, supine chest passes to the clinician, and a rowing machine. All right, for a phase 4 exercise, we are going to do internal external throws with the medicine ball with your shoulder at 90 degrees abduction. So you're going to give the patient the medicine ball. So they're going to be standing in front of you, and then you're going to have your shoulder and elbow at 90 degrees. And then you're just going to internally rotate and flick it back. Throws. So that'll be internal rotation. For external, you're going to have the patient turn around, back, shoulder and elbow at 90 degrees, and then they're going to externally rotate, throwing it back to you. For our second exercise for phase 4 of rehab, we're going to do over-the-shoulder wall passes on an TherEx pad to work proprioception, plyometrics, and it'll kind of simulate a golf swing, so it'll be a little more functional too. So the patient is going to stand on the TherEx pad, facing away from the wall. So they're going to bring the medicine ball and throw it across their shoulder and catch once it hits off the wall. And they're going to keep doing this.
Bibliography.